Good morning, everyone. Our guest today is probably well known to all of us, Dr. Raouf Nakhleh. Dr. Raouf Nakhleh is world famous in his field. He graduated from medical school at Wayne State University, and he joined our department back when for an anatomic pathology residency, followed by a transplantation pathology fellowship and surgical pathology fellowship. He stayed on faculty for a few years and then moved on to Henry Ford Hospital in Detroit, where he practiced in his area of expertise, transplant pathology and liver pathology. And from there, he moved to Mayo Clinic in Florida. Dr. Nakhleh spoke in several conferences worldwide. He held many offices, leadership offices, with the CAP, with the USCP, and we all know him very well. In fact, all anatomic pathologists across the country owe a great deal to Dr. Nakhleh, because no matter what we do in terms of quality assurance, lab management, reduction of errors in surgical pathology, somehow we'll have to link to his work in this area. He published more than 190 papers, won several teaching awards, and he is mostly known in the area of error reduction in surgical pathology. And today we are so glad to have him speak with us in this grand rounds, Evidence-Based Laboratory Practice Guidelines. Dr. Nakhleh.
Well, thank you very much, Dr. Khalifa. It's a very kind introduction. Like we were just speaking, I wish I could be there. I wish I could see you all. As I said last time when I visited several years ago, University of Minnesota is my home for pathology, and it's always homecoming to do this, and I'm delighted to have this opportunity. What I want to talk to you about today is evidence-based laboratory practice guidelines. I had a wonderful opportunity to participate in this, and I want to share with you my experience and show you the relevance to our practice today, because increasingly this is happening. Medicine is really becoming evidence-based, whereas it was not. So let me just jump in and start this presentation. Okay, my goals today is to define and describe how an evidence-based guideline is done, demonstrate the work done by the College of American Pathologists Center Committee, which is where all the activities of the evidence-based guidelines in laboratory medicine is happening, and then outline the impact of evidence-based guidelines on immunohistochemistry. And so let's get started. So what is evidence-based medicine? Evidence-based medicine is the concise, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. It's the integration of best research evidence with clinical expertise and patient values. Medicine probably came along basically as evidence-based medicine or trial and error mostly. Certainly, when I stepped into medicine, it was mostly evidence-based medicine and mostly trial and error. But I think we've made the switch probably late in the 90s and into the next century into evidence-based medicine, and I think it's here to stay. So it's good to understand the whole process and what it takes to do this well. The CEP, as many of you know, I'm heavily involved with the CEP, and I was fortunate enough to become part of the center committee that does the evidence-based guidelines. This was officially launched in 2009 when the Board of Governors approved the center, and the ASCO CAP recommendations for, sorry, I just want to adjust my screen here. The ASCO CAP recommendations for IHC for estrogen receptor and progesterone receptor testing in breast cancer was the first official guideline released under the center. Since then, the center has published 16 evidence-based guidelines and is currently working on 9 more guidelines in process. We've also collaborated with 20 plus organizations in this effort. Is another view of this. Obviously, the center has to be at the center of the universe, but if you look at these are all the projects that we've done, sort of surrounding the center. And at the periphery, you can see the organizations that we've partnered with. The solid lines are partners. The dotted lines are our collaborators. Actually, early on, we decided to be more, we were more partnering, but that took an extended amount of time to actually get all the approvals. So we've decided to go with a model of collaborators since then. Very few of our projects are actually partnered now, with the exception of ASCO, which is an excellent partner and has been for quite a long time. So when you're doing guidelines, you have to have some standard for how you do it and do it well. The Institute of Medicine changed its name to the National Academy of Medicine, and they, in 2011, published Clinical Practice Guidelines We Can Trust, Standards for Guideline Development, and this is what the center follows. There are 7 basic principles. Number 1 is establish transparency. So everything that is done is basically documented and is transparent to everyone. Manage conflicts of interest. Obviously, we don't want manufacturers and people just doing guidelines just simply to sell their goods. You want to maintain, manage the conflicts of interest so that you have the patient's interest at heart. Establish a multidisciplinary panel. Perform systematic review, which I'll explain in a moment. Rate the strength of recommendations, articulate the recommendations, and include external review. So those are the principles to put out trustworthy evidence-based guidelines. How do you do it? Well, there's a lot of steps, and most guidelines typically take, if everything goes perfect, it takes about 2 years to produce a guideline. It's quite a bit of work. I've done a couple of them myself, and I know that it's quite a bit of effort to actually do this well. We've had actually some guidelines take as much as 5 or 6 years before they were completed, simply because they were complex and you're working with other organizations. But essentially what you do is, number 1, select, somebody submits a topic and you select it to move forward, determine the scope, and form the panels that will do the work, do the research and review the evidence, draft recommendations. Once you draft your recommendations, you really have to get feedback from the public or the users and get feedback as to usability. So after the open comment period, then the recommendations are redrafted, re-examined, and then a manuscript is drafted. Then you go through a review and approval process, and then you publish. Beyond that, then you maintain it, and you either reaffirm it over time, update it, or sunset it. And I'll try to demonstrate all of this in the presentation that I'm doing today. So we have typically 2 panels that we put together to do this work. First, you have the expert panel, which is composed of a chair and members. Typically, it's about 10 people. You also have a guideline development manager, which is specifically trained to actually take us through this process of building an evidence-based guideline. You also have a medical librarian, so that your search criteria, that your literature is consistent. The last part of this is a methodologist, which I'll describe before, but these are individuals that are specifically trained to evaluate the literature to help guide the expert panel. There's an advisory panel, and this typically are also composed of members that are expert in that area, in that field. You have the Center Guideline Committee members, which oversee the entire process of the guidelines. And you also can include patient advocates where it's applicable. So the methodologists, as I said, methodologists are specifically trained to evaluate the literature. And quite frequently, when you invite them to be on a panel, they're not experts in that area, but what they're expert as is to evaluate how good that evidence is. So they go through the literature and they tell you, well, there's a risk of bias here because of such and such. They look at the risk of bias, inconsistencies, indirectness, imprecision, and publication bias. And they help guide the expert panel in weeding through that evidence and then coming to appropriate conclusions. The methodologist is a member of the expert panel and participates in the systematic review of the literature. Now, how do you go about actually going through and designing what you want to do so that you gain the understanding so that you can answer your questions? Essentially, you have the expert and advisory panels discuss and develop key questions that a guideline will address using the PICO framework. So the key questions actually are very important because, you know, if you think of a situation you want to ask, you want to get to a point where you can ask the question that is pertinent to patient care. And the simpler that question, the better you can answer it. And so you have to define a patient population, the intervention, a comparator group, the outcome that you're seeking, the time, and the setting. And just from a practical perspective, here's an example of the guideline we're looking at for workup of acute leukemia. And so the population is obviously a biopsy from patients with suspected indolent aggressive or Hodgkin's lymphoma. The intervention is less than optimal types of samplings, such as FNA, low volume biopsy, incisional biopsies, bone marrow biopsies, or samples of bodily fluids. The comparator, or the gold standard, really is an excisional biopsy of tissue. And the outcome that you're looking for is accuracy of the diagnosis, overall survival rate, complication rates, and any kind of artifact that would influence or prevent you from making a diagnosis. And then you define what studies you want to include so that you can go at the literature. So observational, comparative, non-comparative, prospective, and retrospective studies. So what constitutes a systematic review? A well-done systematic review includes the following: clear, explicit objectives with clearly stated inclusion criteria, systematic searching methods that reduce the risk of bias, consistent evaluation of available information such as outcomes and study quality, information about how decisions are made. And obviously this is, to do this well, that's why we use a librarian that actually can do systematic reviews at a professional level. I've done my own reviews and they're nowhere close to what a good librarian will do. And the same thing in evaluating the literature, you need that methodologist to put this all together. So a systematic review is not the same as a systematic literature search or a narrative review of the literature. Then, you have to evaluate what you have. There are conventions as to how you evaluate, and grade is one of those. The center has adopted the grade of recommendation, assessment, development, and evaluation, parenthesis, it's the grade approach for the development, for approach to developing recommendations, and will use it for the development of all future guidelines. Grade is a common, transparent method for grading the quality of evidence and strength of recommendation in healthcare. It is used by many medical societies and healthcare organizations. Actually, it's the one, like in the world of guidelines, evidence-based guidelines, it's sort of the gold standard. So how do you grade the quality of evidence? And you essentially have to put it into these terms. It's either high, moderate, low, or very low. And at the high end, it's where you are confident that the true effect lies close to that of the estimate of the effect. At the low end, essentially you have no confidence in the evidence that's presented to you. And of course you have intermediate things. So you take everything that's given to you from the evidence, you go through methodically, and you review a lot of evidence, a lot of papers. And then you have to kind of put it all together. And you go through a considered judgment process, provides the logical bridge between the evidence and the final recommendations. As no evidence, no paper is going to actually tell you what to do. You really have to put together a lot of papers together to be able to synthesize this. But you also have to include clinical, the clinical situation may or may not be present in the evidence. So as the evidence alone can never tell you what you should be doing in any given clinical or diagnostic situation, the considered judgment process enables the recommendations to be made by taking other relevant factors into consideration. Oops, sorry. So more than just evidence, you come together and you actually have to consider, experiences, the content expert experiences, patient perspective, legal and regulatory requirements, societal values. Those are very important, and cost and implementation. And this is very important because many guidelines now are proposing different recommendations based on cost. For instance, what we do in the US may not be applicable in a third world country without the resources. So you have to manage things in a different way. So anyway, the process is you come together and you consider all these things and you provide your recommendations. Once you provide your recommendations, then you have to grade your recommendations. They're either going to be a strong recommendation, one for which a guideline panel is confident that the desirable effect of an intervention outweighs its undesirable effects, and then vice versa. Or that the undesirable effect of an intervention outweighs its desirable effect, so you would have a strong recommendation against. Conditional recommendations are one for which the desirable effect probably outweighs the undesirable effect. Weak recommendation for an intervention, or undesirable effect probably outweighs the desirable effect, so a weak recommendation against the intervention. But uncertainty exists. So that's how you rate the strength of recommendations. So once you have everything all put together, then you put together a dissemination and implementation. So you define target audiences, and it could be pathologists or oncologists or other groups. And then you sort of form a strategy for dissemination, awareness strategy, whether press releases or social media, or lots of teaching presentations and lots of other publications that maybe help you in disseminating this information. And then you see what comes back. Oops, sorry. then you see what comes back. You put it out there, and then you see what comes back. And people may find your guideline usable or not usable, or certain parts of it good or bad. So you have to look at it down the road. So guidelines are reviewed every 5 years or earlier possible. If noted changes happen, you either reaffirm, update, revise, or retire. The center collects metrics from most of its guidelines to determine changes in practice and/or guideline impact via questionnaires. New ideas, if you have an idea for a guideline, they're always welcome. And there's a way to submit ideas on the CAP website. So that's my general review of an evidence-based guideline. And the remainder of this talk is I'm going to focus on immunohistochemistry. I'm going to start talking about the American Society HER2 guideline, which is essentially the first guideline that sort of impacted pathology in a major way. And it was actually fairly traumatic, I think, to the pathology community when it came on board, because we had to start thinking of things in a very different way. It made demands of pathology that weren't there before. And it actually was quite fascinating to me. And I was intrigued to see whether this was doable or not. And I actually set on to a course to kind of pursue this more. So let me just take a step backwards and just talk a little bit about kind of the regulatory framework for which we do work. Basically, as an anatomic pathologist, surgical pathologist, our morphologic diagnosis is the practice of medicine. It's sort of an extension of a physical exam. Instead of physically examining a patient, we're actually taking their tissue and examining them under the microscope, and we can make a diagnosis that way. It's the practice of medicine. In the laboratory, though, clinical tests, they are subject to CLIA mandates. And that mandate is that if you're going to put a test into practice, you have to do analytic validation so that you are sure that a test, does what it's supposed to. Validation is defined as the act of checking or proving the validity or accuracy of something. This typically involves comparison to known methods or known processes. Now, the other aspect of this that we have to understand is that there's an FDA framework for medical devices. And the reason why I bring this up is that antibodies and immunohistochemistry are defined as medical devices. So there's the FDA classification of a class 1 medical device, and these are ancillary. And typically in immunohistochemistry, these are things that we may use. Sorry. For example, keratin stain is an antibody that we use just to, but the diagnosis is actually made under our morphologic guidance, and the keratin is ancillary to that. A class 2 medical device is where you do testing, and that testing on its own can determine a therapy. And HER2 is that type of test. So it requires more rigor. FDA class 3 medical devices are devices that require pre-market approval. So the FDA has to approve them before they are sold and used. And so this is a framework that we have to understand and that we're getting into as we get into companion diagnostics, as more and more targeted treatments happen for cancers, such as HER2, such as PD-L1, or, there's a whole host of new targets that are being used. So when we use this, we are kind of stepping a breach where these tests are independent now, and we have to apply a certain amount of rigor to them. So, as I said before, when the HER2 guideline came out, I was very curious to find out if laboratories could comply with this. So we did this study. The study was actually done in 2008. It was published in 2010. And we looked at laboratory compliance with the American Society of Clinical, essentially the HER2 guideline. We were fortunate to get 757 laboratories to respond to our survey. And this is the response, and this is the highlights of the results. At the time, we were very concerned that laboratories probably could not meet the concordance with either a FISH test or another IHC test. And we were kind of, when we looked at the data, only about 80% of laboratories could achieve a 95% concordance for negatives, and 73%, 95% confidence for positive. Similarly, there's actually a lower rate when laboratories compared themselves to another IHC laboratory. The other thing that was bothering us about this data is that at least 20% of labs were doing validations with too few cases. And they were also using 2+, which is equivocal cases. I mean, if you want to validate a test, you really should focus on positives and negatives. It doesn't make sense to validate using equivocal tests. So we saw some concern with this, and we actually, at the time, I wasn't on the Board of Governors, but we thought it was important to kind of discuss this at a higher level in the CAP, which we did. We also talked a lot with the people on laboratory accreditation, and they suggested that the typical accreditation cycle is about 2 years long. And so maybe it just takes time. You know, the guideline was released in 2007. We did the survey in 2008. And so maybe, you know, it just takes time for the laboratories to adopt this information and to actually adopt the guideline recommendations. So we said, okay. So what we did is we, in 2011, we redid the study. And laboratory compliance with the American Society of Clinical Oncology, College of American Pathologists, HER2 testing guidelines. So we looked at it in a 3-year comparison to see if there had been some improvements. Lo and behold, actually, we did not see a lot of improvement in the data. This is, you see, this is the data in this table that looked at a comparison with a FISH lab. And so you can see that there's still a substantial number of cases of laboratories that were validating with too few cases at this end. Oops, sorry. At this end. And at the same time, there were still 23, 24% of the cases that they were using for validation were, you know, equivocal, which really shouldn't be used. When they compared to another laboratory, again, the same kind of thing was happening. A lot of laboratories were using too few cases for validation, and they were still using equivocal cases, which really should not happen. So we got this data and we circulated it, and there were other things that happening with the HER2 guideline that so the whole group decided that the guideline should be updated. And anyway, this is a summary of our 2011 survey. A percent of HER2 IHC validation concordance was unchanged. Number of cases used to validate was unchanged. And this led to strengthening of the LAP standards. And so in 2013, or actually it was published in 2014, there was updated recommendations for HER2. And these were them. Now, I didn't discuss this before, but a lot of people, when the 2007 recommendation really objected to this 48-hour limit for fixation, because essentially made it so that you had to work on the weekends. And so a lot of people did studies actually to prove that things were fine longer than that. So the recommendation was changed to 72 hours. And the initial recommendations talked about a validation with 25 to 100 cases, but it didn't have any specificity. This was made much more specific. If you used an FDA-approved test, you needed to validate with 20 and 20. And if you used a laboratory-developed test, you had to use 40 positives and 40 negatives. Also, the recommendation is laboratory must show compliance with accreditation and proficiency testing requirements for HER2 assay specific concordance. So this came into being. Obviously, this didn't exist. Proficiency testing for HER2 didn't exist in 2007, but it did exist in 2011. And 13. So now this could be required. So substantial changes based on the feedback that was obtained during that time. So this is how a guideline evolves over time. And of course, there's been a 2018 HER2 update, which actually is looking very much at the equivocal cases and try to determine that. And I won't go into the specifics of this, but this is how it went. Anyway, so the 2018 basically addressed the equivocal cases, recommended repeat HER2 testing on excisions, may be done but not mandatory. Unusual IHC results correlate with, essentially, you can read these. If you do this, you already know this, but it's not the significance. The whole point is that guidelines can evolve over time, and they should evolve over time based on practice and based on knowledge. So this brings me back now. When the HER2 guideline was presented, it got me to thinking, well, what about all the other immunohistochemistry that we do in the laboratory? Do we need to have some guideline for that? And so to start this off, in 2010, we did this survey of laboratories, and we were fortunate enough to get 727 laboratories to participate. So we were looking at immunohistochemistry validation procedures in the laboratory. And so here's a summary of the survey. Obviously, it was conducted in 727 labs. We asked, do you have validation written procedures in your laboratory? And 68% of them had written procedures for non-predictive antibodies. 46% of them had written procedures for predictive antibodies other than HER2. And generally, we asked them about the implementation of their last antibody. And what that demonstrates is that they were, in general, following the procedures that they had. We did find that gaps existed with doing sufficient validation, and a guideline would be helpful to assist in predictive and non-predictive IHC. And so we set out to actually do this one, do a guideline for immunohistochemistry in general, not just for HER2 or ER and PR as was already published. So this is how kind of the questions that people had. So the overarching questions for immunohistochemistry: what is needed for initial analytic assay validation before placing any immunohistochemical chemical test into clinical service? What are the validation requirements? When and how should validation be evaluated? Should you look at analytic sensitivity, specificity, accuracy, precision? That's what we were hoping the guideline would answer. What is the minimum number of positive and negative cases needed to analytically validate an IHC assay for its intended use? Again, predictive, non-predictive, infectious disease organisms, rare antigens. Should expression levels be specified for positive cases? What parameters should be specified for the tissue used in a validation set? What about cytology specimens? What is the minimum tissue size that you really need to validate this? Should you be looking at neoplastic versus non-neoplastic tissues? And so on. There are many other questions. So all of these questions were used to collect data and to actually put together a guideline, which was published in 2014, Principles of Analytic Validation of Immunohistochemistry, guideline from the College of American Pathologists, Pathology and Laboratory Quality Center. And that was published in 2014 and actually provided, initially, I think it provided 18 recommendations, but after the open comment period, that was all taken in, and it was revised down to 14 recommendations. But I think it proved very useful for a lot of laboratories to kind of get into the framework of doing appropriate validations for immunohistochemistry, particularly when it's coming, for situations where you have a companion diagnostic that is determining treatment. Not long, well, right about the same time as we were publishing this, we had this opportunity to have a CDC Cooperative Agreement grant, for which we got a good amount of money to actually do this and follow up. It was improving the impact of laboratory practice guidelines, a new paradigm for metrics. And as we had already done the baseline IHC validation practices, this was collected in 2010, and the guideline was published in 2014. We thought, well, it would be appropriate to kind of use this CDC Cooperative Agreement to evaluate guideline effectiveness, looking at it into the 2015-2016 framework, and to see if there was impact, what was that impact of the guideline. And then this is a result of this several publications. I'll present to you just two of them. This is one of them, Analytic Validation of Immunohistochemistry Assay, a comparison of laboratory practices before and after introduction of an evidence-based guideline. So this was published in 2017, and it actually looked at the surveys of IHC practices before and after the guideline. And here's, in a nutshell, sort of what we found out. Laboratory has written procedures for assay validation. And for non-predictive markers, you can see in 2010, it was 68%. In 2015, there was 80% of laboratories had written procedures. For predictive markers, we went from 46% to 74%. So I think it's satisfying that laboratories picked up on this and are actually doing this. So we also asked them about their actual practice. In the survey, we asked them, what did you do with your most recent antibody that you included into your laboratory? And so based on that practice, for non-predictive markers, laboratories actually followed their documents, their procedures. This went in 2010 from 86% up to 95%, but for predictive markers, it went from 75% up to 99%. So I think this, laboratories really got this and found the importance of doing this for predictive markers, because the accuracy of these tests are very, it's really needed, and it's very important for patient care. And I think this is very gratifying to see that this change had occurred over a relatively short period. So we also, at the same time, we asked a lot of questions, because realizing that we need more data to actually distribute to other laboratories to find out how you would do a particular thing. And so Analytic Validation of Immunohistochemistry Assay, new benchmark data from a survey of almost 1,100 laboratories. So here's some of the data that we discovered. And this was new data because none of it was known before. 60% of laboratories had separate procedures for predictive and non-predictive markers. 42% had specific procedures for laboratory developed tests. 50% had procedures for testing cytology specimens. 46% had procedures for testing calcified specimens. Minimum case numbers were specified by 86% of laboratories for non-predictive markers and 76% for predictive markers. For initial validation, 75% of laboratories adopted 20 and 20 minimum for non-predictive markers, and 45% adopted 40 minimum cases for predictive markers. Really in accordance with the 2014 guideline. In addition to that, we asked for a lot of information that actually didn't exist out there. And so revalidation of previously validated assay. What is the minimum number of cases specified for non-predictive markers, and here for predictive markers? So we asked laboratories, what are you doing in these situations? When you introduce a new antibody lot, how many cases do you test? When you have a new dilution, when you have a new antibody clone, and so on. What happens if you change your water supply, which can affect actually your results? So for predictive markers, obviously higher numbers. Oops. For predictive markers, you have higher numbers, but and for non-predictive markers, lower numbers. But this is actually a good reference for a laboratory to use if you come up to a situation where you need to, you're trying to figure out what should I do in this situation. Here's a reference that you can use to put this together. So this is kind of where we're at. They are currently working on an update of the IHC guideline. And I don't know if it'll be out in 2020. Things got delayed quite a bit in 2020 based on this COVID-19. But I think this is coming together, and we look forward to a release of an update. And I think it's likely to include recommendations for calcified materials, likely to include recommendations for cytology material. Last year, we went through a process of generalizing requirements for predictive marker in the laboratory accreditation program. And I don't know if you noticed that, but it would be impossible to kind of add new standards for every new predictive marker. So we're having more generalized principles, and that's happening. We still don't know what the impact and possible legislation that will happen with laboratory developed tests. That is, you never know, when you look at Washington, you never know what's going to come down the road. But basically, this is what I've tried to present to you today. Defined evidence-based guidelines, describe what the CAP Center does, and demonstrated how this has impacted immunohistochemistry. I'll be happy to take any questions at this point.
Thank you very much, Dr. Nakhleh. This is Dele here, and it's so nice to hear you, even though we could see you. Dr. Khalifa has been called away for frozen sections. So
I'm just done now.
You're back. Okay. Okay, so back to you.
Yes. So thank you, Dr. Nakhleh, for the presentation. This is great work, and obviously from our end, we see the end product, and sometimes we don't necessarily see what went into developing guidelines. I like your diagram with the global and the interaction with different planets with the central sun, and I see that you went over the interaction between developing guidelines and the compliance and the regulatory. But one thing here was kind of missing in my head, and I hope we want to hear your thoughts about how developing guidelines intersects with the whole medical legal sphere. Obviously, these guidelines and whether people comply with them or not may make its way to the court when a case is being discussed. From the Canadian experience, I am very aware of situations where the whole province was not following the guidelines, and they got in trouble with the court. So while developing guidelines, do we seek input from medical legal experts, or is that side totally uninvolved in developing the guidelines?
Well, this is a complex societal question. When I started, people talked about local standard of care because they realized care could not be the same everywhere. But I think over time, we've essentially come up to national standards of care and national expectations. And, I think we have to frame this with resources, because obviously if you don't have the resources to do something, you can't, I can't force you to buy a $5 million machine just because the guideline says you have to do that. You have to kind of work it this way. But this is kind of the interesting and the difficult part of the guideline, in that you look at the literature and you try to figure out the best possible medicine can happen. But then at the same time, you have to balance that against feasibility. I think, if you completely ignore a guideline, that's trouble. I don't think how you can defend that. If everybody's ignoring a guideline, then that's fine, because you can find many other people that say, that's not worthwhile. But when you do these guidelines, you really want to keep your ears wide open. You want to listen to the ground, and you want to include, that's why we do these surveys, is to get the feedback as to feasibility. I am aware of the situation you speak of, and now I'm not involved in it, which is good. But I'm not sure I can comment on the legal aspect of things. I just think that more and more today, there's going to be a national or an international expectation for how you do things. And evidence-based guidelines will be a major role in that. The guidelines are just guidelines. They're not requirements. But if they make it to where they're adopted into standards, and the government takes note of that, then you have more obligations.
Any more questions for Dr. Nakhleh?
Yes, so I have one question from here. I know you talked about HER2 guidelines for validation, and one of the things there is having to use 20 positive and 20 negative for validation when using FDA approved, and then 40 when you are using an LDT. Now, is this guideline specific for HER2, or is this a general guideline for every predictive testing? And the reason why I'm asking is, you take where I work, and I know you do the same thing in transplants. So we have C4D immunohistochemistry, and different labs use different systems. So using that kind of guideline to use 2020 for C4D in the liver, for example, is practically impossible. So when these guidelines are put in place, the validation requirements, are they always specific to the marker, or what is it?
No, the IHC guideline that was published in 2014 very specifically put in some discussion about rare antigens, where I know it's very difficult to find 20 positive cases of C4D in the liver transplant population. I don't think I've ever seen, I think I've seen one, maybe two in my career. So it's, you know, it's where practical, you know, I don't think it's mandated for everything. The lab director has to use his or her judgment to, as best as possible, validate that antibody. And it may be that you, you know, you have your validation on the kidney cases in this situation, and you know, you extrapolate that to the liver. And certainly hearts are very similar as well. But you know, there is some leeway in the way that this guideline is written. So for rare antigens where you don't have a lot of cases, you are given leeway, but it's up to the laboratory laboratory director to determine that number and what's acceptable.
Thank you.
Any further questions?
We, Dr. Nakhleh, we imagine that now we are embarking on developing more guidelines for COVID testing. Has any project started in this arena?
No, I'm afraid COVID came on us very quickly. Unfortunate, because a lot of things are flying off. Some are good and some are bad, or I should say not good. It takes time to actually develop good guidelines, and I suspect that all this COVID information will be synthesized over the coming years, and we will have more information. I mean, I've been really looking at, for instance, I'm overseeing it. I'm not really a microbiologist, so I'm not part of the testing part, but I've been watching carefully from the CAP's perspective about this COVID testing. And I think, you know, it'll be a while before we actually have good guidelines as to what's happening. Most of what's happening out there, I think people are figuring out based on what they know about other viral infections. And but I don't think that there's any guidelines in the work today on that for testing. There's certainly a lot of problems, particularly with serologic testing. The specificity is very problematic. I'm not sure I can add much to that at this point.
Thank you.
Hey, Raouf, Leo here. I just want to follow up on Mahmoud's question with a comment. We have self-insurance. I don't know if Mayo has that. And I've been on the board of our insurance company for 15 years. So we see all the lawsuits, all the whatevers and what have you.
Right.
We actually perform very well, but you know, any year can take you down. What I would say is I've never seen a case where the lawyers have brought forth issues of guidelines, but I think that's only because they haven't been made aware of that. And once they get knowledge of that, and, you know, if you just imagine some surgical procedure or something that we do where, you know, lymph nodes weren't looked at, or we didn't go that far, or this or that, or whatever. I think it could put, you know, us and others in vulnerable positions once it becomes well known by the legal profession, because they're going to go, well, doctor, your profession has put forth these things, and you mean to tell me you didn't follow them? Why didn't you follow them? And, you know, I think a judge or a jury is going to listen to that type of thing. Yeah. So that's just one anecdote from our practice.
I think in general, laboratory practice and whether AP or CP, we're much more regulated than pretty much a lot of medicine.
Yep.
And so we're kind of used to actually doing the right things, and we've done it for a long time. And I suspect that anybody that's that's been involved in laboratory practice for any substantial amount of time, I mean, understands this. And it's very difficult to kind of like, to go back to the 80s when actually CLIA was, things happened, and that's why CLIA was written. Right. But I have seen it in other countries where practices diverge, and some of it is based on resource, and some of it is just, this is how I do it, and I don't want to change. But I don't think that it's a real substantial risk in the U.S. These guidelines, I mean, they've been around. A lot of people are putting out a lot of guidelines, and it's actually, I think it's helpful because we have to have some sort of basis to make sure that it's based on science rather than something else.
Thank you.
Yeah, so, Raouf, how does CAP react to CAP accredited labs relative to these guidelines?
Well, they do very well. Actually, CAP labs, because they're constantly listening to the CAP, they do very, very well. They actually have a higher level of adopting guidelines, and we've actually shown it in a study or two that I mentioned today, versus ones, for example, like a derm path type situation, which is not CAP accredited. They don't really pay attention a lot to the pathology guidelines. So like we can show a difference, but no, the CAP labs do very well. They're constantly attuned to it.
Well,
Vanessa Dayton here. Dr. Nakhleh, I hope you don't remember me from when we were residents a long time ago in a previous millennium. That was a beautiful presentation. Thank you so much for what you do. And question for you and Dr. Ferkton, Dr. Khalifa, should Dr. Nakhleh's textbook on error reduction in surgical pathology be required reading for all of our trainees so that they will be one step ahead of the malpractice attorneys?
Well, actually,
I love the book. It's a great book.
Yeah.
Well, thank you very much. I do remember you, by the way.
Sorry.
It's actually wonderful to refamiliarize myself with the University of Minnesota. And thank you for the compliment about the book. I try very hard to just put practical ideas out there.
Well, thank you.
I have one last comment, Mahmoud.
Yes, Leo.
To any of the residents that are on the grand rounds, this is what can happen when you train with us. You see Raouf. Thanks again, Raouf. It was a wonderful, wonderful talk.
Thank you very much.
Leo, I hope you are not referring to the lack of hair.
Right.
Well, I think we're all in that same group.
Okay. Well, thank you, Dr. Nakhleh, so much. I wish we had the pleasure of having you physically here. We have dinners and meet, but I'm sure we will meet again, and we will see you in USCAP and other meetings. Thank you so much for today.
Thank you. I appreciate the invitation.
Thank you.
Thank you.